The broadcast is now starting. All attendees are in listen-only mode.
It must have been cold there in my shadow to never have sunlight on your face. You were content to let me shine, that's your way. You always walked a step behind. So I was the one with all the glory, while you were the one with all the strength. A beautiful face without a name for so long. A beautiful smile to hide the pain. Did you ever know that you're my hero? And everything I would like to be. I can fly higher than an eagle. You are the wind beneath my wings. It might have appeared to go unnoticed, but I've got it all here in my heart. I want you to know I know the truth. Of course I know I would be nothing without you. Did you ever know that you're my hero? You're everything I wish I could be. I could fly higher than an eagle. For you are the wind beneath my wings. Did I ever tell you you're my hero? You're everything, everything I wish I could be. Oh, and I can fly higher than an eagle. 'Cause you are the wind beneath my wings. Oh, the wind beneath my wings. Thank God for you, the wind beneath my wings.
Good morning, everybody. This is Dr. Minarsek, and we just started our second song, although we didn't want to. We have to save that for the break. And today is Tuesday. It's October 12th. It's 9 o'clock in the morning here in the Chicago area. And I put up a bunch of cute little stickers, which I have kind of like a addiction to, okay, including a nice sticker for our summary every webinar. But I also put up a gloomy sticker because this is already the 12th day of October, and every single day in October I've been going down to the beach and trying to get a picture, a beautiful sunrise, and only once was it a halfway decent sunrise. All the rest of them, you couldn't even see the sunrise. It was gloomy, and today's another gloomy day, and it was drizzling and raining. But at least we're going to have a lot of bright, nice things here. This is supposed to be Zion, Illinois, where I live, Monarch City, bunch of butterflies, a bunch of bees, nice trees, and the most beautiful park in the world, with 25 miles of hiking trail, and I've hiked every inch probably 10 times already because that's what I do every day. But what I do when I don't hike is prepare webinars. And today's webinar is going to be called Cellular Adaptation, Injuries, and Death. It's actually the official first chapter in the last several editions of Robbins. And there are 66 items we'll be talking about briefly. I usually review them the day before and also like the night before exactly. So why don't we get going? I think you could hear me. I was doing some testing and I heard people say that they can hear me. And so whenever I see your comments there in the question box, I can basically see what you're thinking. Like sometimes the sound goes out and I see somebody writes, no sound. Well, if the sound is good and you could hear me well right now, just say hello. How does that sound? I already see people start putting in a few comments, and I appreciate just glancing at the comments quickly. Oh, I got one hello there. I'm assuming that everybody else can hear me because somebody has already started to respond with the hellos. Okay, let's drop down the ugly guy and put up the PowerPoints. And these are PowerPoints I actually made like over 10 years ago, but every year and every time there's been some type of change or new addition to Robbins, which of course I regard as the Bible of pathology, I usually make a few comments or change it a little bit. So there we go. Today's topic will cover the whole scope of the common cellular adaptations, various things causing cell injury and cell death. The one thing that you'll notice today is that when we talk about the cell being injured or the cell dying or reversible changes or irreversible changes, it's going to parallel what you see in life. When a person dies, has many, many, many parallels to when a cell dies and vice versa. Same thing with injury as well. So we have a few objectives for today. And of course, the main one is actually the title of the chapter as well. We're going to be talking about, once again, we brought this in the last webinar, the anatomic concepts of disease. The degenerative diseases, which is loss of cells in general. The inflammatory diseases, which is disruption of cells by inflammatory cells, different kinds of inflammatory cells, the acute ones, the chronic ones. And the neoplastic disease is the uncontrolled proliferation of cells. So everything we can talk about in diseases at the cellular level, and we talk about life and death, it's at the cellular level as well. So when we talk about cellular growth and adaptations as our first concept, we'll be talking about hyperplasia. And it's exactly what it says, hyperplasia. Plasia means growth and hyper means too much. So too many cells for a wide variety of reasons, whether they're normal or abnormal, is called hyperplasia. And then there's hypertrophy. It's not too many cells, but the cells are generally too big. So you could have an organ that is twice as big as another organ, but it's not because it has twice as many cells, it's because the cells are twice as big. this very, very mysterious concept of atrophy, which you think should be the opposite of hypertrophy or smaller cells. And to a certain degree it is, although commonly in medicine the term atrophy is very often used as too little cells, or the opposite of hyperplasia. So although the term hypoplasia is not really very commonly used, very often the term will be atrophy, whereas the Trophy brothers refer to increase in size of cells. The Plasia brothers refer to the growth of cells, whether they're too much or too little. And then a very, very interesting concept called metaplasia. And I could define it very simply, and we will. It's basically a substitution of one normal type of cell with another normal type of cell. And because we're talking about adaptations, metaplasia is an adaptative process. Okay? And then we're going to talk about all the kind of things that could injure cells, like lack of oxygen, physical injuries, chemical injuries. Actually, three of these are the big ones, which I always call the big three, which is physical, chemical, and very often all of these things, although they're listed separately, they're very much often related to lack of oxygen. Okay, some more objectives we have. We'll be talking about pathologic mechanisms at the subcellular level. Okay, lack of ATP, probably the single one most common factor in cell death. Mitochondrial injury causes lack of oxidative phosphorylation, not enough ATP, not enough energy. Great thing for injuring a cell. Injured cells also take in and collect and sometimes even crystallize calcium. The role of free radicals in terms of being very dangerous or injurious agents to the cell, because a thing that a free radical wants to do is immediately combine to make it not free anymore, is hook up with somebody, and it could be combining with things that it shouldn't be combining with. Okay, and also the concept of membrane integrity. The general rule is, as the membrane goes, whether it's the cell membrane or mitochondrial membrane, as the membrane goes, the cell goes. If a membrane is injured, the cell is injured. If a membrane dies, no longer functions at all, the cell dies, okay? And speaking of cell death now, we have a concept of both apoptosis and necrosis. Now, when I was a little munchkin like yourself, a little buzzard, the word apoptosis never even appeared in the second edition of Robbins. Okay, now it's probably there if you do a word count, hundreds of times. Basically, it's cell death, but it is normal programmed cell death. Cells dying because they have to die. It doesn't have anything to do with disease or injury. But on the other hand, there are cells dying because various injuries are either extended into death or severe enough to cause death, okay? So you could think of apoptosis as normal programmed dying. Cells die because they just have to, as part of a normal life process. Or necrosis, cells dying because of pathologic changes. Or you could think of it as a spectrum too, because besides having apoptosis and necrosis, you can also talk about pathologic apoptosis. But in every case, the morphology is the same in the changes that we'll be talking about. Subcellular responses to injury. Well, what happens to the lysosomes, the smooth endoplasmic reticulum, the mitochondria, the cytoskeleton? What happens to these things when cells are injured or dead? And we'll be talking about them and showing them to you as well. Finally, the last couple of objectives are intracellular accumulations. So if you could think of every type of biochemical in your body, whether it's fat or carbohydrate or protein. These things can accumulate, okay? Also, pigments can accumulate inside of your cells. They can be of any type of chemical substance, or they could be basically coming from the outside, or what we call exogenous pigments, like carbon particles from soot, or what we call anthracosis, or tattoo pigments. So we'll be talking about the changes in cells due to these accumulations. And finally, a comment at the end, which may or may not be surprising to you. We're going to say, why do cells die? It's basically the same as like saying, why do people die? Okay? Do they die because it's just their time to die? Or do they die because their components wear out? Well, there's basically arguments for both sides, but probably most of the time, I think most of the experts, the cellular biologists, will tell you cell dies and people die simply because it's their time. How does that sound? Pretty spooky, doesn't it? Okay, so pathology is the course. This is chapter 1. We all know that patho means suffering. It's a Greek word, and logos is a study of. So pathology is a study of suffering, okay? And kind of interesting because suffering or clinical symptoms is usually regarded as one of the 4 aspects of what makes a disease a real disease. There's a couple others too. In medical schools, which is what this course is aimed at, second-year medical schools, people who have had their anatomy and physiology and biochemistry and whatnot, very often a pathology course, maybe in about half the schools, or maybe less than half by now, divided into general pathology and systemic pathology. And general pathology refers to general things in pathology, like inflammation, like degeneration, like tumors, like genetic diseases, like immune diseases. And then systemic diseases refer to diseases of the classical systems of the body: digestive system, urinary system, respiratory system. Maybe divide that further into upper and lower and so forth. So this course will be both general and systemic. I think the trend has been, because students are always so paranoid or crazy about passing their step exam, I think curriculums now are probably a little more aware of passing their students on the first try. So very often the curriculum has become more and more question oriented. But I would say probably still the most likely type of curriculum, which is basically kind of what we'll be doing here, is systemic pathology as it pertains to the various systems of the body. So when we learn about the digestive system pathology, in most curriculums, or many curriculums, in the United States at least, you'll be learning about, clinical aspects of gastrointestinal diseases and so forth. So there we go. In general, systemic pathology is about twice as lengthy, time-wise, or perhaps megabyte-wise, than general pathology. So I think we're going to wind up having something like about 10 topics or 10 chapters in general pathology, and probably like around 20 in systemic pathology. We said that clinical expression, the logos, okay, pathologos, is one of the 4 things that makes a disease a real disease. Now, probably if you go online or you watch a lot of television, like many idiots do, you'll see a lot of diseases now are very, very fuzzy. I think a lot of diseases are kind of like invented, and they don't really have these 4 classical features, but they're there to basically to sell you something, to take away these little spooky, fuzzy things that they're trying to describe. But if you say you have a disease, if there is a disease present, according to the father of pathology, Rudolf Virchow, who we mentioned last webinar, and we'll talk about him again today. You have to have four things in order to have a real disease. You have to have a cause, and that's called an etiology, okay? Now, sometimes causes are not really clear, but we know of factors that are associated with a disease. So we might call those risk factors rather than cause. You know, believe it or not, there's probably not one single specific crystal clear cause of the world's greatest disease now, which is atherosclerosis. But you can talk about risk factors like, you know, diabetes or cigarette smoking or hypertension. And sometimes if the risk factors are even fuzzy, they won't talk about risk factors regarding a disease. You'll hear just associations. They'll say, well, lupus is associated with blah, 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 blah. That doesn't mean it's a cause. And it doesn't necessarily mean it's either a risk factor. But every disease needs to have some type of cause, even if you don't know what it is. And then there's a concept which is probably the most difficult to explain, called pathogenesis. What's the pathogenesis of a disease? Well, if we have defined diseases at the cellular level, then the pathogenesis, if you want to think of it as a anatomic or cellular or histologic sequence, it is the development of the disease, usually even before any symptoms might even occur, and certainly after the cause, that ultimately lead to the full-blown expression of the disease, which is clinical expression and morphology, okay? Now, the morphology is the abnormal anatomy. Could it be abnormal histology, which is present in almost all diseases? Could it be an abnormal x-ray? Could it be an abnormal lab test? Well, it probably could be. But from the point of view of a pathologist, and I also think from the point of view of you whipping out your prescription pad and writing prescriptions for various diseases, I think you should be aware that of the disease in kind of a histopathologic manner. So, you know, if you're writing if you're treating a patient for a bacterial pneumonia, you might visualize neutrophils inside of alveoli. I hope you do, you know, or a radiologist might think of it as an infiltrate, but it's an abnormal anatomic finding, even if that anatomy is at the cellular or even subcellular level. And of course, you could say that in order to have patho or suffering, you have to have some kind of symptom. So clinical expression. Now, there are many, many diseases that do not have full-blown symptoms. Sometimes they ultimately result in full-blown symptoms. But the clinical expression of a disease is the reason the patient comes to you, okay? Pain, swelling. Perhaps he may have a full-blown disease without any symptoms at all, and it's only present on a lab test, for example. But clinical expression of a disease is the patho of pathology. Okay, here we go. What's the cause of a disease? Well, in some cases, it's pretty clear, crystal clear. Tuberculosis, caused by a bacteria, an acid-fast mycobacterium called Mycobacterium tuberculosis, okay? You could say that's the cause. In many tumors, you might say that there are certain causes, or you might say there's risk factors, but it has to have a cause, okay? Risk factors could be a whole list of things. If I told you there were like 4 major risk factors for atherosclerosis, you'd probably know what they were already, okay? Sometimes there are minor risk factors or minor associations which may either add to the development, pathogenesis, clinical expression of a disease, but they are not very clear. Sometimes they're just statistically related. So you may talk about the cause or the etiology of a disease. You may talk about risk factors. But if that's still not really very, very clear, you just may talk about statistical associations, which, if they are present, may indicate that a disease is or will be developing. And the development, of course, is what we call pathogenesis. So if we have defined diseases at the cellular level, then you could say that the sequence of events or sequence of cellular changes from the initial stimulus or the cause of disease to the ultimate expression or the clinical expression, the symptomatology of the disease. That's probably the best way to think of pathogenesis. I think the best two words, when I think about this over the years, that probably define pathogenesis would be insidious development, often before the actual symptomatology of the disease happens. And of course, the morphology. Most diseases are available, invisible, detectable, diagnosable at the microscopic level, sometimes at the gross level. And you want to know something? You would be amazed how a lot of people, a lot of pathologists, including you who will be seeing plenty of microscopic diseases, you'd be amazed how those microscopic changes can be seen very, very clearly, even at the gross level. Okay, so you have a liver that is congested. I guess you could say that's a disease. But grossly, you might look at it, or you might look at it with a magnifying glass, and you could see congestion of the central veins or the central portion of the lobule. Okay, so microscopic changes, more often than you think, can be suspected grossly. And of course, the radiologist would love to really understand and see the disease microscopically, but unfortunately, he has densities and shadows and proton spins and echoes to deal with. So you can talk about a radiologic morphology as well. And finally, more and more, we could probably think of diseases, especially in the last 20, 30 years even, at the molecular level. Mutations, okay, or alterations in molecules, so to speak. So I would say that almost invariably, every disease has to have a morphology. And I know what you're thinking. You're thinking, well, what about schizophrenia? You know, I know something. I wouldn't be surprised if at some point in time, even now molecular changes are suspected, I wouldn't be surprised if my statement that every disease has to have a morphology will be unquestioned. Okay? The more and more deeper we look into the microscope, into the electron microscope, into the genes, okay? So clinical expression is the symptoms. That's the fourth thing that makes a disease. And it's the patho, it's the symptoms. And there are a wide variety of real diseases in which the patient has no symptoms. Very, very often, those symptoms will appear at some point in time. But it would not be right to say if a patient doesn't have any complaints, then he doesn't have any diseases, okay? That would be a horrible statement to make, okay? But if a disease is present, but the patient has no symptoms or complaints or pains or fevers or swelling or anything like that, then you could call that a subclinical disease or subclinical expression. And very often those will lead to downright symptoms. Now let's talk about this concept of an image, okay? This is a pathology course. The diseases that we talk about, almost all will have some type of image. It might be a photograph of the patient, okay? It might be something cut out at autopsy or at surgery, okay? It might be a microscopic disease. And in the 600 or 700 slides we'll be seeing this year, these very often are going to be regular H&E or hematoxylin and eosin microscopic images, the things that you basically need to diagnose over 90% of all diseases. Sometimes they might be not present on H&E, and you have to do a special type of stain, or you may have to go into an electron microscopic view to see certain changes at the subcellular level, okay? Whereas I'd say almost all diseases, and certainly all diseases in my collection, will be light microscopy, and most of them without a special type of stain or immunochemistry, okay? You could have images of the disease radiologically or even on a molecular basis. You could think of an array of genes which are either present, absent, or mutated, okay? And you might think of that because some of those are colorful arrays, you know, pinks and blues and greens and yellows. You almost might like to think of it as a regular microscopic slide at the light level. But from the point of view of pathologists and from the point of view of this course, most of the diseases that we show and talk about, we will find the diagnostic features, the image at the microscopic level. It would be very, very nice if when you treat these diseases as physicians, if you just get a visual feel for the alterations in histology, excuse me, the alterations in light microscopy that you will be treating. See this guy here again? We mentioned him briefly on the last webinar. His name is Rudy Virchow, Rudolf Virchow, the father of pathology. Okay, he died over 100 years ago, but before he did, he said something that was even more profound than another guy who lived 100 years ago, and that was Einstein. He said that basically all diseases are due to alterations of cells. And that's why he is the father of pathology. And that's why if you go to a pathology meeting or a party where there's a lot of pathologists and you say something bad about Rudolf Virchow, you know, some people may start pushing you around or punching you, okay? Now here's another guy. Amazingly, that looks like Rudy Virchow. And this is the man who wrote the Bible of Pathology. This is Vinay Kumar. He's the chairman of pathology at the University of Chicago. He's my friend. He's a super nice guy. And I'm sorry if I confused the two, but in many respects, they are both legends and will be immortal, okay? So far, we've been all anatomy heads. We've been thinking about abnormal anatomy. We've been thinking about abnormal cells. We spent almost the whole webinar last time looking at microscopic alterations of normal histology. And that's good because visualization of disease is what we have when we talk about the disease anatomically or the morphologic changes. But there's another way to define disease, and that's homeostasis. And that doesn't have a damn thing to do with anatomy. Now, I want to tell you something. There's basically two kinds of people, and there's two kinds of medical students. And one of them are like me, and probably more than 50%, maybe 70 or 80% of the people think of diseases as alterations in anatomy. But the smarter people think of diseases as functional changes, okay? So you might have abnormal cells, but cells have functions. So if those functions are interfered with, if their normal balance of checks and balances are interfered with, if there's some reason to have some overproduction of a compound or underproduction, then that's a disruption of function or disruption of homeostasis. So another way to define disease is to think of alterations in normal checks and balances of physiologic processes. You know, some people might think of that word as pathophysiology. Now, when I was a medical student, there was no such thing as pathophysiology. We had pathology courses. Now I've noticed throughout the country that very often there are no more pathology courses, but there are pathophysiology courses. And I'm wondering why that has changed. And what I've also noticed that counterbalances that is that most pathology, or especially pathophysiology courses, are not taught by pathologists. But you could be damn sure that if you have a pathologist, you know, in good medical schools teaching pathology, they're not going to let some pimp call their course pathophysiology. Okay, so we've been talking about cells and diseases in general. Now, how can we talk about the ultimate catastrophe to a cell, and that's cell death? Well, one of them is a normal process, nothing to be sad about. It's called apoptosis. So when you think of all the cells that you had in your body when you were an embryo that you no longer have, guess what? They're dead. And the result, they were replaced with more normal cells. Some cells just have high turnovers, like the crypts of a GI tract, for example. The crypts of Lieberkühn, you might remember that from histology. Okay, well, in order for a cell to turn over a lot, or bone marrow cells, or blood cells, or white cells, they have to die. And that's normal pre-programmed cell death. The parts of the body that have high mitotic turnovers normally, you know, for example, epithelial cells versus connective tissue cells, basically all have to die at one point to be replaced by other cells. Now, another type of cell death at the other end of the spectrum is called necrosis. Okay, and these are cells that die due to diseases. The process by which normal healthy cells die, whether it's apoptosis or necrosis, are morphologically the same. You see changes in the cytoplasm, changes in the nucleus, maybe engulfment by phagocytosis of macrophages, okay? The changes are the same, but the processes are different. So that's what we're going to be spending some time on, probably in the next hour. But let's also introduce the concept of plasia. Did you ever see Snow White and the Seven Dwarfs? Of course you did. Every kid has seen that. There were 7 of them. Well, I found about 7 plasia brothers, and they remind me of the 7 dwarfs. The most common plasia concept is hyperplasia. If plasia means growth, then hyperplasia means hypergrowth or too many cells. Hypoplasia is the opposite of hyperplasia. It's not enough cells. Okay? I guess technically, if you use the word aplasia, that's not only not enough cells, but it's no cells. Now, one term that is very rarely used, and I very rarely used it in my pathology reports, but that's normalplasia. That's normal. In other words, the presence of cells in a certain area is about what you would expect to be seen in a normal person at this time in their life, let's say. But then there's metaplasia, a very, very common term, and we defined it earlier, but let's talk about it again. Metaplasia is the replacement of one type of normal cell with another type of normal cell. And almost always, the reason why certain cells are replaced by other normal certain cells is an adaptive response. So, for example, if you have a columnar mucosa, but it's subject to a lot of friction or perhaps a lot of trauma, that might metaplase into multiple layers or a squamous. So squamous metaplasia is the most common type of metaplasia, and it's the replacement of columnar single layer cells with multiple cells, usually secondary to some type of traumatic or inflammatory process, okay? But you could go the other way around. You could have something like a squamous mucosa that is now being replaced by a columnar, and that's also an adaptive response. So let's say you normally have squamous cells in the lower esophagus, but there's a lot of acid reflux, okay? Well, then that squamous mucosa might be replaced by a columnar mucosa. Why? Because columnar cells, especially mucus cells, are alkaline and they reduce acidity. Okay, well, that's a reason for an adaptation. The word dysplasia most of the time refers to cellular changes that can be seen which precede the development of a malignancy. So you could have normal cells here, and with time they turn into malignant cells. Well, they don't just do that all of a sudden. It might take weeks or months or years for them to actually turn into malignancy. And during that time, you can't call them normal, you can't call them cancer, but most of the time, not all of the time, most of the time they may or will turn into a malignancy, and that's called dysplasia. Now, there are other diseases, especially in pediatrics, in which the word dysplasia is used, but it has nothing to do with precancer at all. The word anaplasia is identical to the word cancer or malignancy. So tissue that is anaplastic is cancerous. It's infiltrative. It's invasive. Okay? Sometimes in the literature, you'll often see the word frank anaplasia before the word anaplasia. And that refers to the fact that it's just downright malignant. So anaplasia is malignancy, but frank anaplasia is downright obvious malignancy. It's no longer atypical. It's no longer dysplastic. It's frankly malignant. Here's hyperplasia. Probably the best example I could use, and I've used it over the years. You see those adrenal glands in the middle row? Do you see the yellow? That's the cortex. It's yellow because it has a lot of fat. And this one is the right adrenal gland. How do I know that? Because it's flat. And here's the left adrenal gland. How do I know that? Because it's not flat. Okay, the right adrenal gland generally looks flat simply because the liver presses down on it onto the kidney, whereas in the left there is nothing like that. So anyway, take a look at the thickness of that yellow cortex. We call it the cortical ribbon. It's about 1 millimeter thick. You see, here's a scale down here, and that thickness, that fairly uniform thickness, is about 1 millimeter. Well, look, on the top, it's hardly visible at all. So that would be a decrease in number of adrenal cortical cells. You might call that hypoplasia. Unfortunately, many people call it atrophy as well. And even though that's not really a correct term, it's used so often you cannot say it's wrong, okay? Now take a look at the yellow ribbon on the bottom. It's more than 1 millimeter. It could be 3, 4, 5, 6, 8 millimeters. That's hyperplasia. So what do we have in the middle? Normal number growth of adrenal cortex cells, yellow because they have a lot of cholesterol, and fatty substances also always look yellow. Hypoplastic adrenals on top, and hyper on the bottom. Could there be a tumor that was producing ACTH? That would be a good cause for hyperplasia, wouldn't it? What about the top? Why would these adrenals on top have very little or reduced number of cortical cells or hypoplastic. Well, maybe the guy's on external steroids and it was feeding back to the pituitary to shut off the ACTH, okay? So there's hypoplasia on top. There's hyperplasia on the bottom, and those are your normal adrenal glands in the middle. Let's talk about the trophy brothers. We've already talked about the plasia brothers. Trophy doesn't necessarily refer to number of cells. It generally, technically, refers to the size of cells. And there's a lot of exceptions to the rule. But a substance that is hypertrophic doesn't have an increased number of cells. It has a normal number of cells, but the cells themselves are thicker. So a hypertrophic ventricle that weighs twice as much as a non-hypertrophic ventricle, it doesn't weigh twice as much because it has twice as many cells. It weighs twice as much because each cell is about twice as big as it should be. And technically, the opposite of hypertrophy would be hypotrophy. But that word is hardly ever used. And you want to know something? If you would say that atrophy or atrophy is extreme hypotrophically, you probably can. But very often, hypoplasia, okay, like in this adrenal gland over here, they would say, oh, that's not hypoplastic. They often might call that atrophic or, okay. Now, the word dystrophy, let's talk about that because that's a common word referring to diseases. And it really does not have a clear-cut meaning, okay? And it's used very, very often in pediatric diseases, okay? And a dystrophy is generally a very vague term, and it just refers to the fact that something is abnormal, okay? There's hypertrophy. Let's say that heart weighs 400 grams, and let's say that heart weighs 800 grams. Is it twice as much because there are twice as many cells? Or is it twice as much because each cell is twice as big as the normal cells? Yes. So hypertrophy is increase in size of cells, classically speaking. Hypotrophy, once again, it's a term that you very rarely hear it and you very rarely see it in the literature, but it would technically mean the opposite of hypertrophy, which now is the decrease in the size of the cells. However, when you have, for example, a left ventricle that is much smaller than it should be, or a right ventricle because of some congenital defect, they very often might call that aplastic rather than hypo or atrophic. So atrophy is technically decrease in the size of the cells, yes. However, very often the term atrophy is used instead of hypoplasia. Okay. Now there's a lot of things that cause atrophy. Why would disease processes, cause cells to be smaller than they should be? Okay. Well, one of them is that they have a decreased workload. What happens if you don't use your muscles? Okay. Your myocytes, whether it's cardiac muscle cells or skeletal muscle cells, become smaller because they have a decreased workload. As an opposite, what happens if a muscle cell has an increased workload? Then it becomes hypertrophic, doesn't it? What happens if you denervate a muscle, especially a skeletal muscle? Well, the fibers become smaller because the nerve kind of acts not like a blood vessel, but something to keep it normal in function and in size. What happens if you decrease blood flow to a tissue, to a muscle cell, to a liver, to anything? Well, the cells are like people. If they don't get enough food, if they don't get enough oxygen, then they become smaller. You know, if I didn't get as much food as I normally do, my stomach would become smaller, okay? Sometimes things become smaller simply because of aging, and that's usually secondary to some type of decrease in hormonal nutrition, so to speak. So you can have atrophy due to aging. The classical example of that might be a thyroid gland. I bet you when you were doing your anatomy last year and you were cutting out people's thyroids, you were looking at the book and you're saying, hey, the book says this thyroid should be about 10, 15, 20 grams, and this one's only 7 or 8. Well, that's because with aging, and usually due to hormonal withdrawal, glands and tissues can become smaller and cells become smaller. There's another concept called pressure atrophy, okay? And that's related to decreased blood flow. What happens if you have a muscle or an organ or a tissue, but you put physical pressure on it? You know, you lean your arm over a chair all night, or you have some type of prosthesis that puts pressure on you. The tissues that are supplied by the blood vessels, the arteries that are being fed, will now have decreased blood flow, decreased nutrition. So that's the concept of pressure atrophy. Now, let's talk about something we mentioned, but we'll say it again. Let's talk about metaplasia. Okay? It's a substitution of one normal cell or tissue type for another. Okay. The most common example of metaplasia is called squamous metaplasia, where you normally have columnar cells. If you have now, as an adaptive process, if they're being subject to trauma or inflammation or whatever, they turn into squamous because they need more layers of cells to adapt to the pressures that are put on them. And the columnar metaplasia would be a place like the lower esophagus, where you normally have squamous cells, now becoming columnar, simply because they're subject to perhaps a lot of acid reflux, what they call Barrett's esophagus. Why? Because goblet cells, columnar cells, mucus cells neutralize acid. Squamous cells don't. Sometimes you can have what they call osseous metaplasia, in which you normally have fibrous tissue, perhaps a scar secondary to some previous injury. Now you could see perhaps some development of a little bit of bone. That would be osseous metaplasia. Now, why did I put this little X on the bottom? Because I'm putting it here to show you of a junction. It's called the squamo-columnar junction. You have it in the lower esophagus, you have it in the cervix, and you have it in the anal rectal area. One side of this is squamous, and the other side is columnar. So when squamous crosses that line to go into columnar, that's squamous metaplasia. When columnar crosses that line to go into squamous, that would be called columnar metaplasia. And that would be probably the best and maybe the only real good example would be in the lower esophagus. Here we go again, cell death. Apoptosis versus necrosis versus pathologic apoptosis has to ask you at the cellular level, what is cell death and what is cell life? What is not cell death? You know, these are very, very philosophical, soul-searching terms, and I don't want to make it, you know, this is not a philosophy course, but it's very easy to say that when a cell irreversibly, forever, loses its function, you could call that dead, okay? So you should probably define death versus life and not think of it so deeply, and think of it as reversible changes versus non-reversible changes. So the real question with people or even with cells, is not what is death or what is life, but what is reversible or irreversible. Cellular changes that are reversible is not death. It's very often injury. But when a cellular change is irreversible to the point where that cell or that person cannot sustain normal life or function anymore, then that's irreversible. So we should probably not think of cells as being dead or alive. You could probably think of them as being reversible or irreversible. So what would be some of the common things that cause reversible changes? Well, how about oxygen? What about the mitochondria receiving the oxygen and wind up spitting out ATP to provide the energy biochemically for most cellular functions? That would be a reversible change. If there's damage to the mitochondria or reduced oxygen to the mitochondria and resulting in ATP depletion, then that might be a reversible change. What about if the cell swells? Okay, well, what does the cell membrane do? Okay, the sodium potassium pump. It keeps out the sodium, doesn't it? Well, what if that membrane is damaged reversibly? Then that cell could swell. Now, does a swollen cell mean a dead cell? No, not necessarily. The processes could be reversible. That's why they're called reversible changes. Does the lack of ATP or reduced oxidative phosphorylation mean is a cell going to die? No, it just means it's temporarily starving or needs oxygen. If that is restored, it's reversible and it could be normal again. But what are the classic irreversible changes? Well, if your mitochondria cannot supply ATP, okay, oxidative phosphorylation, then if it's irreversible, that cell will die. What about the membrane? What if the membrane defects, due to a variety of causes, which we'll go into, are no longer correctable or reversible? Then they're irreversible, okay? So I think a good rule would be if the mitochondria die, the cell dies. If the membranes die, the cell dies. Now there's also another concept called lysosomal digestion. Now, lysosomes are a little bag of digestive enzymes in the cells. Now, what would happen if those enzymes, rather than digesting the things they should digest, actually started to digest the cell itself? So when a cell dies, there are mechanisms which are complicated biochemistry, and they're triggered off where the lysosomes start to auto-digest the cell. And not only that, but there are even more complicated mechanisms, or signals, so to speak, where a dead cell would then trigger off phagocytosis of that cell and ultimately digested by the lysosomes of the phagocytic cell. Usually a macrophage, but it also could be a neutrophil as well. Let's get back to the concept now. Reversible changes cause injury. Injury is not necessarily by itself irreversible, but if it's sustained or more severe, it could be. So reversible changes to the cells are injury. Irreversible changes result in cell death. What's the connection between the two? If the injuries are prolonged and or severe, you then revert. It's no longer reversible. You now have irreversible changes or cell death. You know, we're about halfway done. So you know what? We're going to take about a 10-minute break. I hope I have been clear in explaining things. and I'm at your level and I'm not talking above you, or you're not saying, hey, why is that guy being so simple? Every idiot already knows this. But if we take about a 10-minute break and play 3 more songs, we'll come back and finish up. And we probably will not have a lab today, but we'll be having often labs, microscopic labs, at the end of other chapters. So let's pop open the music box again, play 3 more songs, and we'll see in about 10 minutes. Well, I thought there was another song on there, but maybe there wasn't. So let's cut it off. And those 2 songs were pretty long, so we certainly took our 10 minutes, actually 9.5 minutes. So let's go back to the second half of the webinar and finish up. Here we go. Put on the ugly guy again. Because usually during the 10-minute break, I think of things that I should have said, but I didn't. Or maybe I just got inspired to say something else, but I couldn't think of them while I was talking about other things. So here are a couple things. First thing I thought I got during the break, I'm going to hide the second one, is where we are. So when I make my little notes, usually about halfway through is when we take our break. We've covered about the first, 31 items. And we'll go down to 66. And it's going to move pretty fast. So we really are commencing pretty well. And we're not going to run overtime. I hate to run more than 2 hours because it's really not fair to reward you for listening carefully for 2 hours by making you listen more. Here's the second thing, stage fright. I always get pretty bad stage fright before every webinar, especially at the beginning of the year when I haven't given them for a few months. And this year I didn't give them for almost a year, so I was terrified. But now I could tell when they're going pretty good or pretty bad. I could tell whether I suck or whether things are going well. And I know that the first half we were doing pretty well, assuming you are who I know you are. So let's go into the second half now and finish up talking more about cellular adaptations, injuries, and death. Did you ever see a movie called The Usual Suspects? It was a famous movie, oldie now, but it was a movie about guys that were put in front of a lineup because whenever there was a crime committed, they always pulled out the guys because often it was one of these guys that committed the crime. So when we talk about injury, you could think of it as a crime. Injury causes reversible changes. If these are reversible, it could be dead. What are the common things that cause cell injury? Now, I'm going to show you the top 3 suspects or the 3 worst criminals. And whenever you talk about injuries to cells or things that cause disease, these 3 things are always kind of categorized. And you probably know what they are, but they're not mutually exclusive. And they very often are related to each other. And here's the big 3. Physical agents, like trauma, radiation. Chemical agents, and that's the whole field of pharmacology and toxicology. And then the infectious agents, okay? These are the agents. Now, we have other things that cause diseases like genetic, but think about it. These agents may and often do produce mutations which could result in genetic alterations. Another thing to remember is that you might say, do these agents interfere with your body's immunity? Okay, are they related to immunologic causes? Of course they are, because if your immunology is in perfectly good order, you wouldn't get any diseases. So almost all diseases, no matter what they're caused by, physical, chemical, infectious, you could think of them as being some failure in the immune system or immunologic. But here, probably the biggest thing, but they don't normally list it, is decreased oxygen. We talked about that as being the most common reversible cause of injury and maybe the most common cause of cell death as well. So they are not mutually exclusive. They're basically adjectives. They overlap with each other. But if you read, when we go into systemic pathology, you read at the different ways, different types of diseases, they're very, very often lumped and categorized as the usual suspects, or physical, chemical, and infectious. Okay? Now, remember we talked about the reversible changes as decreased ATP, perhaps because of mitochondrial damage, increased intracellular calcium. An injured cell has accumulation of calcium because it can't keep calcium out, especially if there's some membrane problem, okay? An injured cell can contain free radicals, but it can also be injured because of free radicals, basically common molecules that are not connected, like the HOH, broken into two parts. Okay. Another reversible mechanism is cell membrane permeability. The more the membrane becomes permeable, the more things leak in, the more things leak out, the more the cell would swell if it loses its ability to keep sodium out. And that can be reversible, but it can also precede the irreversible changes. So once again, an irreversible change is death. And if you wanted to keep it simple, you could say that death is irreversible mitochondrial function, or it looks like a misnomer here. Dysfunction is regarded as abnormal function by itself. So if the mitochondria dies, the cell dies. If the membrane dies or has profound or irreversible changes, the cell dies. So that's how you define death. And it's much, much, much harder to define life. So I wrote this down yesterday. Probably the best way to define life on a cellular basis is to say it's not dead, okay? It sounds like a cop-out, but that's the best I could come up with. Now, we said that death is the result of irreversible changes. The irreversible changes are preceded by reversible changes, but once that cell is dead, you may not be able to know it's dead. If you do studies at the subcellular level or electron microscopy, you may be swollen mitochondria, intracytoplasmic blebs, disruption of the nucleus, okay? Things you might not normally see on regular light microscopy, but certainly on light microscopy you see a variety of changes, which we're going to show you. And very, very often, if it's seen or visible or detectable or diagnosable on light microscopy, you may also tell just from the gross appearance as well. And I'm going to tell you something. The difference between a good and a bad pathologist, and usually the good pathologists are the older guys, okay? Because whenever I was in a pathology group, it was the older guys that they always went to when they had a problem case, because that's the guy that had always seen everything a million times. But usually the older guys, or the better pathologists, can tell even from gross appearances whether the cells or the tissue or the organ or the person is dead or alive. Here we are at the electron microscope level, okay? You normally might see some microvilli on the edge of a cell, but look, you have some disruption of these mitochondria, you have the introduction of vesicles. Those are very early changes which you might see in death, okay? As the changes become more irreversible, if there is such a thing, you could then see bigger vacuoles, more disruption of the membrane. And I'm not even sure if you see a nucleus here yet, but certainly a light microscopic feature, which is usually seen even before, is the shrinkage and the increased hematoxylin staining of the nucleus. Okay, that's called hyperchromasia. It's also seen with malignancies, but the process by which a cell shrinks and becomes darker, which is seen in early death, is called pycnosis, okay? And then as that cell starts to then fragment, okay, broken up, that's called karyorrhexis. And as those fragments are then digested by lysosomes or from a macrophage, that'd be called karyolysis. So pycnosis, karyorrhexis, karyolysis. Pathologic terms not usually used very, very often in clinical medicine. Here's light microscopic changes. Well, you see fibers here. Okay, we're not going to say what kind of fibers they are, but I'll tell you, they're cardiac muscle fibers. Okay, these don't look too bad. You got nuclei both at the edge of the fiber as well as in the middle. You could see some branching, with adjacent fibers, you really can't necessarily see the striations very well. But I'll tell you, in reality, in most biopsies of cardiac or even skeletal muscles, sometimes it's pretty hard to see them. But what do you see here on the right? Hey, what happened to the nuclei? Well, they already have been karyolyzed. Not only have they shrunk and gotten darker, but most of them have disappeared. And when the nuclei have disappeared, that's when the body, the cells, the immune system recognize it as dead tissue. And one of the common, if not the most common, besides bacterial infections, one of the most common reasons for influx of neutrophils is when the body knows that a certain tissue is dead. Now, in this case, it happens to be an early myocardial infarct, where the fibers have lost their nuclei. Usually right after that, you start to see the influx of the neutrophils chewing up the dead tissue. Okay? I guess you could call that necrosis. It's certainly not apoptosis, because the cardiac muscle fibers you're born with should be the ones that you die with. They don't multiply during your life, okay? So as long as we introduce the term now of necrosis or dead cells due to various disease processes, I want to give you a little list of adjectives. Remember, these are not mutually exclusive. They are very commonly used in clinical medicine as well as pathology, and they have certain names, certain adjectives that are put before the word necrosis. Now, we could do this if we have time, but if you go to a dictionary called OneLook and you plug in the word necrosis, a couple years ago, there were 153 adjectives or terms that preceded the word necrosis. I looked it up yesterday, and now there's 192. So that doesn't mean that there's 192 different types of necrosis, because these are merely adjectives. But the more common ones I got here is about 6 of them, or 7. In the brain, when you see dead brain tissue, that's very often described as liquefactive necrosis, because of the nature of brain tissue. Whenever cells die, there's a lot of edema or water or liquid which forms in it. And think about it. The more liquid, the more water, the more H2O, which is water, and therefore the more H, which is a proton. So necrotic, dead, injured even tissue, very often has increased MRI signals simply because it has increased protons because of the increased water. Because isn't every water molecule 2 protons? Okay. Sometimes the word gangrenous necrosis is used kind of as a double thing. I wouldn't call it a oxymoron, but if something is gangrenous, it's generally necrotic. It's dead tissue. It usually refers to extremities. It can refer to the bowel. It's a relatively non-specific term. But the sub-adjectives wet or dry gangrene are often used as well. Now, wet gangrene is necrotic tissue that has a lot of water associated with it. Dry gangrene is necrotic tissue, very often extremities, in which there is no water. It's dry. And we used to have like a lot of fights about what comes first, wet gangrene or dry gangrene. And there's a lot of arguments about it. But rather than think of it in terms of time, think of it in terms of reaction. If necrotic tissue has an inflammatory reaction because there's a lot of water around it, that's wet. If necrotic tissue does not have a lot of water because there maybe hasn't got time to have an inflammatory edematous reaction, that's dry. The term fibrinoid necrosis usually refers to blood vessel walls that are necrotic, very, very commonly in rheumatoid arthritis. And that's because the wall of the artery which is usually smooth muscle, of course, is a little bit more granular and a little bit redder than normal cytoplasm. In fact, it stains a little bit more like fibrin. Now, I know fibrin stains pink and everything in the body stains pink, but fibrinoid necrosis is a pinkish tissue microscopically that is a little bit redder and a little bit more granular. Now, here's an interesting one, caseous necrosis. The Spanish word for cheese is queso, okay? So something that has caseous necrosis, when you cut it with a knife, it crumbles just like cheese does, okay? So that's the concept. It's a gross observation that when you cut something that's necrotic, it crumbles like cheese. So that is the general concept, but when you hear the term caseous necrosis, it's usually referring to tuberculosis. And even though I told you it's a gross term, when cutting it with a knife, very, very often they'll talk about caseous necrosis microscopically. So the term caseating granulomas usually refers to tuberculosis. Fat necrosis is a tissue where there has been trauma to fat, and it's most common after breast surgery. There may have been a lot of surgery in a breast, and the fat now has certain features to it grossly and microscopically, where it's not nice and soft and yellow anymore, but it has a different texture, and there's some infiltrative giant cells and fibrous tissue and so forth, and hemorrhage. Now, here's something that may sound like it's double, okay? Ischemic necrosis. If something has not received enough oxygen, in which many of the different types of necrosises are, including the stuff we talked about up here, if something has not received enough oxygen and it dies, that could be called generically ischemic necrosis. Sometimes it's called avascular necrosis. Sometimes avascular necrosis is called aseptic necrosis, and that's often used with respect to bone that has not received enough oxygen to a whole wide variety of reasons, okay? Radiation necrosis is usually the result of disruption of blood flow as well, okay? Sometimes you may hear the term papillary necrosis, and that refers to the fact in the papilla of the kidney, part of the collecting system, you have hemorrhage and cell death, and that has a kind of an interesting differential diagnosis as well. So these are all the various types of necrosis. Maybe we can show you some pictures of them. Here's a brain. You could see that. It's been cut. Maybe there's an area of hemorrhage here, but you could tell it's not really normal. And microscopically, you see there's an area in this brain which you can already tell. The density of cells and the pinkness is not normal. It's edematous. There's water. That's liquefactive necrosis of the brain. Almost any injury to the brain, whether it's a tumor, whether it's radiation, whether it's a stroke, is going to result not only in water or increased water edema, but also perhaps some increase in the glial cells of the brain, which act often as the immune cells of the brain, much like lymphocytes and macrophages act as the immune cells in the body and the brain. The microglia very often are the immune cells. Here's another brain. This one happens to be MRI, and you can see the frontal lobes here are very, very white. Why is that? Well, there's been some kind of damage. Could it be a stroke? Could it be a tumor? Could it be trauma? It could be anything. But any type of necrosis or injury to the brain, we will probably result in liquefactive necrosis or increased water. And the more water you have, the more protons. And the more protons you have, the more you can spin those protons and produce MRI images. Here's a lung. You could see that here's a diaphragmatic surface. Here's a major fissure. And you could see it's yellowish. Now, what if I told you that this was an autopsy lung, and the guy that cut through this lung with a knife, not a microtome, microscopically, but with a regular knife, said it felt like it was crumbly. It's dead necrotic brain, but it's crumbly. Well, it crumbled like cheese. That's called caseous necrosis. However, if he put some of these areas that are necrotic, these whiter areas, under a microscope, he might see necrosis microscopically as well. And they might even be necrotic granulomas, which TB is. And they might use the word caseous microscopically as well. Although you usually cut cheese with a knife, not a microtome, okay? Here's a blood vessel. This could be a rheumatoid arthritis or some primary type of arterial wall inflammation. You don't see the smooth muscle fibers anymore, but instead you see pink, maybe a little bit pinker than usual compared to the eosinophil areas. The eosin areas. And you could see that it's a little bit more granular. Maybe you have to use your imagination, but that's fibrinoid necrosis. Fibrinoid necrosis usually refers to necrosis of arterial walls. But technically, any type of necrosis in which the staining was a little bit redder and a little bit more granular, because it's stained like fibrin, might or could be called fibrinoid necrosis. Okay, well look at, here's a foot. It's gangrenous. You could tell that right away. You could see that not only is it dead, black, gangrenous, but you can see there's a lot of puffiness around it, like water. So would you call that wet gangrene or dry gangrene? Well, you call it wet gangrene, right? Could that precede the dry gangrene? It could. Could it come after the dry gangrene? Yeah, it could. Here's another foot. Here's a toe. It's black. It's dead. It's gangrenous. It's necrotic. You call it gangrenous necrosis. You call it gangrene. But there's no water or inflammatory or edema reaction around it. So you just call that dry gangrene. Okay? Here's some more examples of necrosis. Often we said that the word ischemic necrosis usually refers to a type of necrosis in which there has not been enough oxygen or it's hypoxic. But let's say that you have an area that has ischemic necrosis because of hypoxia, and you now introduce or you reperfuse that area with oxygen. The classical example of that are coronary artery bypass grafts, okay? You may be taking dead heart tissue and now you're introducing new oxygen in it. You go, wow, that's great. Maybe it'll come back. Well, the fact is, you might be feeding oxygen to the inflammatory or destructive reaction rather than to the part that needs the oxygen. So that's called a reperfusion injury. It's when you reperfuse something with oxygen, blood, and it gets worse rather than better. Okay, that's the probably people that are getting stents and bypass grafts and other types of artificial vascular procedures. That's probably the number one worry, okay? And of course, we said that one of the big three, one of the usual suspects, was chemical injuries. You know, and that's like the whole field of pharmacology in itself. That's something that you'll be spending probably about as much time learning about as you do pathology. Okay, the fact that it could be, dose related and, all kinds of things. Once again, it sounds like a broken record now. This is probably the 10th time we said this. Ischemic injuries, ischemic necrosis, produce a pattern of cellular changes which are usually called an infarct. Okay, if you have dead tissue because of lack of blood flow, lack of oxygen, you can call that an infarct. It has a certain pattern. Besides necrotic pattern, the cells may have secondary inflammatory changes. They may lose their nucleus. Infarct of certain tissues basically shows various patterns. We're going to be dealing with that extensively in one of the upcoming chapters called hemostasis. But the histologic and gross or microscopic appearance of dead tissue is called an infarct. And it's always secondary to lack of blood flow. We talked about reperfusion injury, going to an area where there has been cell death, cell necrosis, but the reperfusion actually makes it worse by creating new damage by feeding oxygen to the inflammatory cells, which are reacting to the dead tissue. Of course, in chemical injury, whether we're talking about common medicines or anything that you might be prescribing, where there's a dose relationship, chemical injury can produce free radicals, damage DNA, cause mutations, cause damage at the organelle level. So that's one of the big three of the usual suspects. Besides physical injury, we have chemical injury. And we said a lot about apoptosis, but what we haven't said about, is we've defined it as normal cell death as opposed to pathologic, which is death due to injury. But what we haven't given you are examples, more examples of normal apoptosis. If you remember from your embryology course, there was a whole wide variety of cells which were present in embryos, which you just don't have anymore. Well, where did those cells go? Well, they must have died, right? So that's an example of normal apoptosis. Okay, when there has been a lack of hormonal nourishment or development or growth to an endocrine gland, okay, because maybe the stimulating hormones are now decreased, you call that hormonal involution. What would be some good examples of that? People on steroids are feeding back to their adrenal cortex in decreased amounts, and therefore those cells have died. People, elderly people, usually have smaller thyroids than non-elderly adults. What about areas where there's high turnover, like the crypts in your large bowel, okay? Those cells turn over every day or so. What about bone marrow cells like lymphocytes and macrophages, and especially neutrophils? They only have a lifespan of sometimes only a few days, maybe a week or two. Well, they have to die too. And that's another example of normal apoptosis. What happens if you have a pneumonia and your lung is filled with neutrophils as part of the inflammatory reaction, and that pneumonia clears up? Well, what happened to all those inflammatory cells? Well, they die too, okay? Sometimes in your immune system, if you have a cell that is not recognized, whether it's a foreign cell or an intrinsic cell, like an autoimmune disease, or if it's a tumor cell, okay, it could be cleaned up by triggering off mechanisms of T cells and macrophages simply from the fact that it's not recognized as being normal to your body. Now, in pathologic apoptosis, this is, remember, part of the spectrum. You can have toxic effects on cells, whether they're pathogens, whether they're chemicals, whether they're physical agents, and they could cause them to die. And I guess you could say you're now bridging upon a necrosis. Probably necrosis might be a better word than pathologic apoptosis, but I wanted to introduce you to this intermediate concept because it's in the pathology books. If you have obstruction to some duct of some type, the cells that might normally be transported through that duct no longer can go where they have to go to function, so they die. Okay? Probably another great example of pathologic apoptosis are tumor cells. What if I told you that you may now have hundreds, thousands of tumor cells in your body, but they are not being recognized as your tissue, so they're being cleaned up by usual immunologic mechanisms, macrophages chewing them up, T cells recognizing and sending the signals to macrophages and whatnot. That might be another example of pathologic apoptosis. So remember, when we say apoptosis is a normal function and necrosis is a pathologic function, don't always think of them as being completely separate. It's basically part of a spectrum. You have normal cleanup apoptosis. You have this intermediate called pathologic apoptosis. And then you have downright necrosis due to disease processes. What happens to a cell with apoptosis or necrosis? Well, there's a decrease in the cell size. It's no longer functioning. It's no longer taking on the nutrients that it needs. The cell shrinks, and the nucleus shrinks too. But not only does it shrink, but it becomes darker. And that increased darkness or hypercolor is called hyperchromasia. So a hyperchromatic cell could very well be a cell where the nucleus is darker, or it could be a tumor cells frequently take on the hematoxylin dyes in increased amounts as well. The nucleus becomes smaller or pycnotic, and usually when it becomes smaller, it becomes darker. Then it fragments, called karyorrhexis. Then it actually starts to get dissolved or chewed up by the enzymes of the lysosomes or macrophages, and that's when the nuclei are gone. The nucleus is no longer there. We saw that in the picture we saw with the myocardial infarct, where the cells were reacting to the fibers, and most of those fibers didn't even have a nucleus anymore. Also, we saw on the electron microscopic level, as well as the light microscopic level, the membrane fails and you have blebs within the cytoplasm. And of course, the end stage to apoptosis or necrosis is phagocytosis, usually of a macrophage. Okay, it also could be a neutrophil, like we saw in the heart. But aside from normal neutrophils and macrophages, quite frankly, I can't really think of any other type of cell that normally has phagocytosis as its function. Some of the tumor cells rarely can be phagocytotic, usually malignant cells, but for the most part, when we talk about phagocytosis of dead or dying cells, whether it's apoptosis or necrosis, we're talking about macrophages or neutrophils. There's the nucleus of a cell. At this stage, it's already started to fragment, but look, before it fragmented, it actually got darker, smaller, and that's shrinkage of the nucleus, shrinkage of the cell, increased hematoxylin or basophilia of the nucleus, fragmentation of the nucleus, and finally, dissolution of the nucleus. Here's another example, microscopically, of phagocytosis. You have here a cell, and you can see that there are even some red cells inside of it. But these are the phagocytes, the macrophages. Pathologists love to call these things histiocytes, but don't be fooled or confused. When you hear the term histiocyte, they really mean macrophage. In the biochemistry of apoptosis or cell death, you have a generic wide group of enzymes called caspases, which break down the proteins. There are nucleases breaking down the DNA and RNA. And finally, there are signals, mechanisms, where that dead cell is now recognized by a phagocyte, usually a macrophage, which finishes the job and chews up everything. But remember, it may have already been partly digested from its own lysosomes as well. Okay, so in the subcellular responses, going down to the organelles now, we can see the lysosomes auto-digesting parts of the cells with a wide variety of digestive enzymes. The smooth endoplasmic reticulum is activated. The mitochondria swell, just like the cell swells, because they are bounded by membranes which are failing. Don't forget, mitochondria are also bounded by membranes, so the mitochondria can swell. Okay, and then the various aspects of the cytoskeleton, the actin, the myosin, the microtubules, a wide variety of intermediate filaments are digested as well at the subcellular level. Okay, we've said a lot. Okay, we've said a lot about cell injury and cell death, and a lot of it was repetitive, but I hope you have a picture in your mind now of the things that happen when cells are injured, what causes them, and when cells die. What about cells that accumulate substances? Well, either normally or pathologically. So if you take the whole field of biochemistry of the human body and divide it into lipids, carbohydrates, and proteins, basically these substances can accumulate inside of cells. You know, neutral fat accumulates inside of an adipocyte, and very often you don't even see the cell, the cytoplasm of the cell, because it's just loaded with fat. And anything that's a fat, whether it's neutral fat or cholesterol, when it's processed in the pathology lab, the fat substances are dissolved, so they appear like they're clear, like clear holes. So neutral fat cells will be mostly spaces. The proteinaceous substances usually stain pink, and they can be called hyaline. So any proteinaceous accumulation within a cell might be called hyaline. Okay. The carbohydrates, especially in the form of glycogen, can accumulate. There's a whole wide family of glycogen storage diseases in which the enzymes required for the breakdown of glycogen are not present, and therefore they can accumulate, and they can appear to be washed out as well when you look at it through regular light microscopy. And there could be a wide variety of pigments in a cell. Okay, these are things that might come from the outside of the body, or exogenous pigments like tattoo pigments, or anthracotic pigments, which are soot particles, or they could be things that normally appear in your body and have just accumulated within a cell. And they could be proteins, but basically they usually are proteins, but they could be carbohydrates or fatty-like substances as well. And finally, calcium. We told you that an injured cell has an increase in calcium. The calcium can even crystallize, okay? And you could have calcification within a cell for a variety of reasons. But let's go into the fats first. Whenever you look at a tissue grossly, and it's primarily fat, whether it's neutral fat or cholesterol, it looks yellow. Remember, we saw the adrenal cortex and it looked yellow? And that was because almost all lipids look yellow grossly. But when you put this tissue through tissue processing, you pass it through some fat-soluble solvents, like xylene, for example, and the yellow substance or the fat substance washes out. So then it appears clear microscopically. So here, let's make it very simple. If you see something that's yellow grossly, but clear microscopically, it's probably a fat. In fact, I really can't think of anything else it could be. Good examples of fatty liver. Livers are normally brown. Okay, whether you're at the butcher shop or at an autopsy. And the more fat that accumulates within this liver, which you see with diabetes and alcoholism and obesity, as the three most common causes. But when you see a liver go from a brown to a yellowish brown and almost to a yellow, that's almost certainly because of fat. Okay? So that means when you looked at this liver microscopically, what you saw yellow is now clear, because you could see these wide open spaces were all fat, neutral fat, which have washed away. Now, if these spaces are very, very tiny and they're within individual liver cells, that's called microvesicular fat or microvesicular steatosis. Steatosis means fat. If the fat are larger than cells, much larger, like these globules over here, that's macrovesicular. So you might probably have concluded already that macrovesicular is more severe than microvesicular. Here's another kind of fat called cholesterol. Maybe this is inside of an atherosclerotic plaque, which is loaded with cholesterol. Sometimes in the earlier or more mild stages, the cholesterol could be inside of macrophages. They call these foam cells or cholesterol macrophages. There's one, there's one, there's one, there's one. But as it gets more severe, there's probably a 4 or 5 in a row here. But as the cholesterol builds up, individual macrophages can no longer contain them, and they can form these little needle-like crystals, and they're called cholesterol clefts. Okay? So almost as a knee-jerk reflex, if you're looking at an area, particularly, let's say, an atherosclerotic plaque, but cholesterol can build up in other places, like a gallbladder or other places. Excuse me. When you see these little slit-like washed out spaces, you almost instantly think that's a cholesterol cleft, C-L-E-F-T. Last topic, pigments. Okay, there's two kinds of pigments. There's exogenous, or material that's come from outside the body. And there's endogenous. These are substances which pigment a cell, but they normally occur within the body. Now I'm going to make this real easy for you. Almost all of the exogenous pigments, like tattoo pigment or anthracotic pigment gotten from breathing dirty air, like in Chicago, or a place that's heavily industrialized, or coal miners, okay? They're almost always really, really, really black microscopically. And they're usually inside of macrophages as well, because that are the cells that chew up foreign particles. If they're endogenous pigments that normally occur in the body, like melanin, like bile, like lipofuscin, which occurs in increased amounts with aging of organs like heart and liver, or hemosiderin, which is the breakdown of blood pigment. These things do not look black, black, black. They usually have kind of a refractile, glittery, orangish kind of appearance, and they can be confused with each other. So, like, if you see pigment in an area where there's been hemorrhage and it's granular and refractile, you're probably not going to call it melanin. You're probably going to call it hemosiderin. If you see pigment inside of at the base of the skin, you're probably not going to call it hemosiderin. You're probably going to call it melanin. Okay, if you see that at the deep layers of the epidermis. Here's skin. You could instantly recognize stratum corneum, epidermis. This is the papillary dermis, the looser dermis that interdigitates with the epidermis. And then here's the deeper, more densely fibrotic dermis. And look at all these really, really, really black macrophages here. They're so black you can't even see the nucleus. This is what a classical tattoo looks like. So when you see something that's really, really black as a tattoo, it might just have a bunch of pigmented macrophages in the dermis. Okay? This grossly could look very, very black. Here is another exogenous pigment. It looks like it's a lung. Maybe it's a lung from a coal miner, but you see how black it is? It may look very, very black more on the outside of the lung or subpleural area rather than deeply, because that area is rich in lymphatics. And if you're rich in lymphatics, it's also rich in macrophages. And you can see in the lung here, you can see these black pigmented areas taking up the anthracotic pigment. Smoker's lung, soot particles, coal miners, this is anthracotic pigment. It's present in just about every human being that's ever been born and taking a breath, but it's present in large amounts in people that are exposed to polluted air and particles. Okay, this is a lung on the left, and it's congested. And look at, there's all these pigmented cells in the alveoli, and the pigments is kind of a golden orange brownish thing, and it's granular. This is almost certainly breakdown of blood pigments. You know, blood goes from hemosiderin to, it goes from heme to various intermediates, and finally breaking down to an end stage hemosiderin. So when you see hemosiderin, you think that there has been hemorrhage, and the more hemosiderin, the more chronic hemorrhage. So a lung or an injured area that has a lot of these pigmented hemosiderin cells may have been a lung that was congested. Hey, let me tell you something interesting. Let's say that this patient here on the left was in heart failure. So therefore, his lungs have been congested for a long time. And when your lung is congested, the blood breaks down. And then you ask him to give you a sputum, and you stain the sputum. And you see a bunch of these hemosiderin-laden macrophages. You know that there's been a lot of chronic hemorrhage in the congested lung. So you could probably, and they have been called, heart failure cells. Doesn't that make sense? Here's a lymph node, and you can see there's areas that are pigmented, and technically you don't know what this is. It's kind of blackish, but there are certain areas that aren't so black. So could this be anthracotic pigment? Could this be melanin? Could it be chronic hemorrhage? Sometimes you don't know. So there's a wide variety of special stains that you can order, which are fairly specific as to whether it's hemosiderin. They use the Prussian blue stain, or melanin. There's a HMB or S100 stain that differentiates that from the other endogenous pigments. Calcification, finally. Calcification often occurs where there has been old injury and fibrosis. You know, fibrosis, we'll be learning about that in the next webinar, is the end stage of inflammation often. And there's been a lot of fibrosis and collagen deposition from fibroblasts. You could then have often, usually with age, as this becomes older, a type of calcification which is localized. And it's called dystrophic calcification by convention. On the other hand, let's say you have a patient that has hyperparathyroidism, so his serum calcium is sky high. Well, this could result in calcifications all over the body. And this term is called metastatic calcification. So dystrophic calcification is localized, usually the result of injury with fibrosis. Metastatic calcification is secondary to hypercalcemia due to any reason. And one of the most common reasons is hyperparathyroidism. Now, remember, we're calling this metastatic calcification, but it doesn't mean metastatic disease. Okay, and we got down to our last PowerPoint, and I'm happy because we've talked for 2 hours now, and I hate to keep you going after this. So, you may have asked yourself at this point, why do cells age? Why do people age? Why do cells die? Why do people die? Okay, it's almost a philosophical question. But when you look at it from a scientific point of view, you might say cells or people die simply because it's their time to die. And that's the predominant theory, okay? There's basically two facets to why cells in people die and get injured and get old. But there's another theory called the wear and tear theory. Well, maybe this person has been so active and done so many things, the things are worn out in his body. Maybe that's why he ages. Maybe that's why he dies. Well, if you want to look at it as basically a two-pronged approach, the programmed theory, in other words, it's just his time to die, just like with apoptosis, versus the wear and tear theory. The predominant theory, which I think you could say is probably about 4 times more popular than the wear and tear theory. So, as a final thing before we play our last song, you want to know, why do cells and people die? It's simply because it's time to die. Okay, how about if we play our last song and we'll call it a day, and you can't say I kept you more than 2 hours then, okay? I did pick out a good song at the end, which is kind of inspirational, and that's how we'll close it with Whitney Houston.